and good morning from Salt Lake City. Um, I want to spend today, give you a little overview of the journey. We're going to look at what to expect going into the 2020 election year. It should be a quiet one compared to previous ones. That was a joke. Uh, Talk a little bit about price transparency and consumerism, financial performance, as well as two important social issues, the opioid crisis and social determinants of health. When you look at the top stories for 2019, at the top of the list, politics and reform, Affordable Care Act, prescription drug, transparency, all were major areas of focus politically. Another area of focus is consumerism and mergers, ongoing consolidation, the financial status of our healthcare system, hospitals, physicians, as well as the payer sector. And we will go into some of the financial detail of that. And then finally, social issues such as the opioid crisis and social determinants. Sarah, I believe we have a poll question.
Okay, let me go ahead and launch that. Okay, in our first poll question today, we'd like to know, in your opinion, what was the top healthcare story in 2019? And your options are number 1, Medicare for all, option 2, court challenge to Obamacare, option 3, social determinants of health, option 4, the opioid crisis, and option 5, consumerism. We'll give you just a few moments to submit your responses there. If you joined us late, we are recording today's session. You will have access to the slides, so no worries there. And we do encourage you to submit questions throughout the session today. We will have a Q&A session at the conclusion of today's presentation. Okay, people are quick on the draw today, so we're going to go ahead and close that poll, and I'm going to share the results. So it looks like 20% voted for Medicare for all, 11% voted for the court challenge to Obamacare, 9% for social determinants of health, majority here, 50% with the opioid crisis, and then 9% with consumerism. How does that line up with what you would expect, or what you think the top story was?
I'm surprised. I mean, the opioid crisis is clearly in the news, and it's clearly a catastrophic challenge for our country. But I would have put the court challenge to Obamacare and the impact of what that will have on healthcare and the uncertainty that it will lead to. Moving forward, I'm going to talk about the political scene. A year ago, we did this talk here and made some projections about politics, and not all of them came true. But we all need to brace ourselves because there is only 28 days before 2020 election year begins. So let's see what's happened in the past and what we think will happen. The 2018 midterm elections ended a little over a year ago. We, of course, had a divided House, or divided Congress, with the Democrats controlling the House and Republicans controlling the Senate. What this meant was tremendous gridlock. So it meant that the ACA could not be repealed legislatively. It also meant that the Republican position of repeal and replace was dead on arrival as well. Democrats continue to focus on preserving consumer protections, such as pre-existing conditions, improving the marketplace, that is the insurance exchanges, and the Democrats came out really charged up about Medicare-for-all, and I predicted that the House would actually put a Medicare-for-all bill out for consideration and potentially pass it. Of course, it would have been dead on arrival at the Senate. In the Senate, the Republicans focused on other issues such as telehealth, red tape relief, and state empowerment. But what's most interesting is the fairly large number of common areas: opiate epidemic, oversight of mergers, price transparency, rural health, and prescription drug pricing. So let's see how some of those issues worked out after we look at our deadlock status. The Affordable Care Act, borrowing from Monty Python, I'm not dead yet. The act is continuing. It's been it cannot be legislated away. Just before we did our presentation last year, the Texas District Court Court ruled that the act was unconstitutional. Many legal scholars have questioned the position of that court ruling. It has been elevated to the Fifth Circuit Court of Appeals, and oral arguments were heard in July. Interestingly, the Trump administration and the Justice Department, who historically has a responsibility for defending a federal act or statute when it's challenged in the courts, has chosen to actually support the plaintiffs on this, and has come out in support of repeal of Obamacare. This is why I thought this is the most important issue of 2019. If the appeal is successful, 21, or is unsuccessful, I should say, and the district court's opinion is upheld, 21 Americans will lose insurance coverage. Of course, nothing will happen until the Supreme Court weighs in, and that will not happen until next year. In the absence of any constructive legislative action, with the deadlock in Congress, the executive branch continued to pass executive orders lowering the cost of short-term insurance plans, reducing support for the insurance exchanges, reductions in Medicaid spending, and expanded use of health savings account. We all can, who you have high deductible plans, can save more money in our HSAs. One last bullet point that didn't get included in the slide deck, but the administration also has banned access to the insurance exchange for those with illegal immigration status, and that has currently is under court review. I want to now turn to the topic of Medicare for all. As I said last year, I thought the House would pass something to support Medicare for all. Going into the midterm elections, 59% of Americans said they supported Medicare for all, compared to 38% who oppose. That's a 21% delta between the two positions. Today, that difference is only a 4%. The decline in support for Medicare for all and the increase in opposition to it has been quite dramatic. And this is going to have a pretty profound impact on the Democratic nomination process. If you look at this next slide, here's the candidates' positions. Those who are faded out in the slide have already dropped out, and again, the slide's not up to date. There's no rewards in getting your work done early. Governor Bullock dropped out of the race yesterday, and candidate Sestak dropped out about a week ago. So, but if we look at this slide, the Democratic slate of candidates is split almost evenly between for Medicare for all and opposed, but three of the front runners, Sanders, Warren, and Buttigieg, are in favor of some version of Medicare for all, and the only other front runner, Joe Biden, is opposed. So it's an interesting. Oh, oops, I forgot about one. Bloomberg is running too. Michael Bloomberg is running, and he falls into the prefers something else other than Medicare for all. So very interesting. Now here's the other interesting and impactful position. A smaller number of Democratic candidates oppose, basically, essentially should get rid of private insurance. Sanders and Warren want to abolish all forms of insurance except a national health plan. Buttigieg is somewhere in between the two extremes of a national plan or sticking with the ACA, and Biden, the other front runner, is does not want to see anything done to existing insurance plans. And here we go again. Yes, you did mess up my slide, Michael. He also is on the moderate side of this split and does not see any need to get rid of private insurance. Now, here's the more interesting thing. These are the people who are going to vote. 55% of Democrats or independents who lean Democrat want to build on the existing Affordable Care Act, or Obamacare, and only 40% believe that Obamacare should be replaced by Medicare-for-all. This is going to play out pretty significantly, I believe, in the Democratic nomination process. And I'm surprised that given where Medicare-for-all was just a year ago and how it played out in the midterms, that Democrats, as Democratic voters, have a much more moderate view of this. And again, these are the engaged Democrats and not independents mixed with Republicans. So that's still a large percentage who want to see the Affordable Care Act maintained and strengthened. Another big issue that came out of 2018 was Medicare expansion. A year ago, 5 states either passed ballot resolutions calling for Medicaid expansion or elected governors who were in favor of Medicaid expansion. Of those 5 states, 4, Idaho, Maine, Nebraska, and Utah, all expanded their Medicaid offerings, Medicaid access. Kansas was the other one we expected to flip over to include the Medicaid coverage expansion. The governor is pro-expansion, but that did not get through the legislation in 2019. And another unique example is Wisconsin, which expanded Medicaid access to health care, but did not do it under the framework of the Affordable Care Act. So in a practical standpoint, they're more like a Medicare expansion state. There still is legislation pending in Kansas, North Carolina, and Wyoming, which has a reasonable chance of passing in 2020. And 3 states, Missouri, Oklahoma, and South Dakota, will likely have referendums in 2020. So this is one thing we can predict, is that regardless of the outcome of the presidential election, regardless of the politics and candidates running, these ballot proposals are going to move more states closer to adopting Medicaid, the Medicaid provisions under the Affordable Care Act. And if we look at the Democratic candidates on Medicaid, they're unanimous in supporting Medicaid expansion regardless of income. And I did not get a chance to check Michael Bloomberg's position, but I assume he is supportive as well. Other big issue was prescription drugs. Now this is, as of last Friday when I was reviewing my slides, I thought I was going to tell you we are going to have some bipartisan prescription drug legislation. The Senate Bipartisan Prescription Drug Reduction Act was sponsored by Chuck Grassley, a Republican from Iowa, and Ron Wyden. It was approved by the Finance Committee by a 19-9 vote. That was a bipartisan vote. You see in the lower right-hand corner of your PowerPoint, Donald Trump is with Chuck Grassley, and Donald Trump came out and President Trump endorsed the Bipartisan Prescription Drug Reduction Act. There's a different bill that's in committee, has gotten through committee, but has not come to the floor of the House, that is similar to the Senate bill, but a little bit more progressive in the sense that it gives Health and Human Services the ability to negotiate drug prices and also can help private insurances reduce their cost. And then that slide, that graph on the bottom left, that is what has happened to total prescription drug spending since, it's long ago, I can't read the fine print, since 1980. So this is why this is such an urgent issue as prescription drug prices get out of hand. And I'm amazed. I'm a diabetic, and a bottle of insulin costs over $1,000 now. Back in 1980, it was in the $25 to $40 range, and when recombinant DNA insulin came out, it was in the $100 to $200 a bottle range. And the cost of insulin, if you don't have insurance, is outrageous. I had no idea that the prices had crept up that quickly. So this is a real issue. However, it came out in the news on Sunday that the Senate Majority Leader, Mitch McConnell, is unlikely to bring the bipartisan Prescription Drug Reduction Act to the floor of the Senate. There are still a large number of Republicans that oppose the bill. Now, in the Senate, it would only take a handful of Republicans to support this to get it over the edge. But McConnell does not want to run the political risks of Republicans voting against the bill or it passing, given the lack of unanimity within his own caucus. So that looks like this may be dead for the current year. Moving along, price transparency. President Trump's issued an executive order last June, and he had already made a request that an executive order that prices be more transparent prior to this, but this is a bit more aggressive, and they want prices not to be posted as billed charges, but to actually reflect what people pay. It's a novel concept. For those of us who are familiar with healthcare finance, we know that billed charges are almost a fantasy and have very little direct meaning to consumers, unless they're uninsured consumers and are self-paying. And there's also a lot of pressure on insurers to provide clear information about out-of-pocket costs. These proposals or executive order are opposed by both hospitals and insurers. And the big concern among insurers is that if hospital prices are available and people can tell what their insurance pays for a service, then the ability of insurance plans to negotiate competitive prices will be undermined, because everyone will know what the insurance company is willing to pay what's the lowest price they're willing to pay for, let's say, an open heart procedure or a total hip replacement, and every hospital will be and what they're willing to pay for their highest price, and every hospital will understand that, and it will make things very competitive. Despite all the gridlock in Washington, D.C., Medicare is continuing down the path of supporting alternative payment models, and one of those models would be the accountable care organizations. In 2018, they launched Pathways to Success, and it shortened up the transition to downside risk in terms of accountable care organizations. That led to a fairly significant drop, 8% decrease in the number of ACOs or ACO contracts. And you can see this data on the lower left side of your screen is tracing, the blue lines are tracing number of contracts right through the third quarter of 2019. So very recent data. But the orange line with that nice uptick at the end is reflecting the number of covered lives. So covered lives actually increased by 3 million despite 8% of the ACOs dropping out. And also, interestingly, physician-led ACOs are participate in at-risk ACOs at a higher rate than hospital systems do. In terms of total contracts, those have continued. The yellow line in the middle on the graph on the lower right corner is commercial ACOs, which have continued to climb during 2019. The red line is the Medicare ACOs with that drop in contracts that I just discussed. So overall, ACO participation has been relatively flat over the past 2 years. That slight downtick driven by those hospital and or CMS-based ACOs, which have dropped out due to the risks involved and the potential losses that could happen. That said, alternative payment models are expanding. Back in 2015, 62% of all healthcare was provided in a traditional fee-for-service environment. In 2018, that has dropped to 39%, and that would be the Category 1 payments. Category 2 payments are traditional fee-for-service. However, they have a care coordination reimbursement or pay-for-performance aspect to it. So this would be your hospital-based value-based purchasing would fall in this category, for example. And we can see that's increased from 15% to 25% over the last 4 years. And the alternative payment models, which include things like shared savings, shared risk, and bundled payments, as well as population-based at-risk contracts, those have increased from 23% in 2015 up to 36%. Interestingly, the Learning Action Network, which is closely aligned with the insurance industry, has had a set a goal for 2018 for that Category 3 and 4 to hit 50%, so still shy of goal, but again, still expanding. And we can anticipate going into the future that there will be more alternative payment for healthcare delivery, and we expect that Category 3 and 4 to continue to climb. It's certainly consistent with CMS's policies, and certainly is happening on the commercial side of the equation as well. Bundled payments continue to expand. Bundled payments are now voluntary since 2018, so that when the bundled payment for care initiative Advance was launched in 2018, it included it became voluntary. The second cohort of participants start in January 2020, and there'll be additional cohorts going into the future. If you have any plans to be in the second cohort, you probably should get off this webinar right now and go finish your application because it is due today. And the new for 2020, there'll be 31 inpatient and 4 outpatient episodes that will be subject to bundled payment, and this does qualify as an alternative payment model. Currently, there are close to 1,300 participants across the nation, you can see where they're located on the map adjacent to this. So is CMS's strategy working? If you look at the growth in Medicare spending per beneficiary over time, you can see that it's been relatively stable from 2014 forward, when there was a big push towards increasing the amount of quality-based and at-risk contracts. And in fact, Medicare has done a somewhat better job of managing spending than the commercial sector, the private health sector. And I don't see any likelihood that CMS will back down from this position. And there's certainly, the current administration supports the accountability and risk associated with the Medicare strategy, as did the previous administration. And for that matter, these policies began under George W. Bush, and so this has actually been a bipartisan strategy here around ACOs and so on. I'm going to shift gears to consumerism, and really ask the question out here: are healthcare providers ready to compete? If you look at this graph, the blue lines are those which senior executives and healthcare providers, among healthcare providers, thought that was a high priority strategically, and what percent thought they had high capabilities to achieve them. So if we look at the first one, improving customer experience, 81% say this is a high priority for their organization. 11% of them, however, think they have the capabilities to do it. And we go down to as we move on to other areas, like the next highest priority, offering a variety of facility-based access points. 61% see it as a high priority. Only 10% believe they have the capability. Using digital tools to engage consumers, 42% see it as a high priority. Only 4% believe they have the capability right now. And so the question really is are healthcare providers ready to meet customer needs? If you look at this slide, the dark blue is a consumer-friendly offering that allows convenient access and scheduling. Then that's for the slide on the left. So walk-in hours, 58% of health providers do not provide them. Save a spot at an urgent care, same thing, 58% don't provide. Same day appointments, 63 don't provide it. Online self-scheduling, 67% don't provide it. Evening and weekend clinics, 68% don't provide it. 83% don't allow online self-scheduling for new patients. Moving to the virtual health slide to the right, site-to-site specialty care, 69% don't provide. Direct-to-consumer telephone visits, 77% don't provide. E-visits through an online questionnaire, 77% do not provide it. 80% don't provide direct-to-consumer video visits, and 95% lack off-site kiosks. So a lot of things that consumers are looking for are not available. Telehealth, this is another way to meet consumer needs, and some of the virtual things we were talking about in the previous slide are included in telehealth. In 2019, Toby Cosgrove said 2019 was the year of telehealth, and there has been growth in the use of telehealth, and there have been some true success stories. Jefferson Health hit the 100,000 telehealth visit milestone in 2019. Sanford Children's Hospitals, 3,500 telehealth visits in primary and specialty care, and home monitors for type 1 diabetics and single ventricle patients. Sam's Club, Amazon and Sam Clubs are doing virtual clinics and home visits for their employees, and CMS continues to push telehealth and put pressures on healthcare to develop programs. In 2019, virtual check-ins were reimbursed by CMS. Remote evaluation of pre-recorded patient information and interprofessional internet consultations were reimbursable. In 2020, CMS will expand the number of codes for new telehealth services, and a lot of these are focused on the opioid use. And 2 additional states since last year require that private insurers cover telehealth the same as they cover in-person services. So telehealth is making progress and will continue to. In terms of financial performance, health system mergers, a lot of hospital action, some notable mergers that came out last year. HCA and Mission Health closed a deal in February of 2019. Community Hospital System sold 3 Virginia hospitals to Bon Secours Mercy. Sisters of Charity joined the Cleveland Clinic. Big one in Louisiana, Oustomer and Lafayette General planned a merger for the 33 hospital system. Health plan mergers between Priority and Total Health Care. And another big one, University of Louisville acquired Jewish Hospital from Kentucky One in August of 2019, or planned to merger. I don't think that's finalized. And Sanford Health and Unity Point called off a $11 billion merger, which was big news. 2018, 21 hospitals closed. By June of this year, 11 have closed, so that trend is continuing. And overall, you can see the number of deals that are happening in the industry over the past 5 years and the number of hospitals involved. So there's continued consolidation of hospital and health systems. What is More interesting is this disruptive integration which is taking place. We've heard about Cigna and Express Script, CVS and Aetna, Walgreens and Humana, and United Health Group and DaVita. These are all sending shivers up the back of traditional healthcare providers. So here's another source of what concerns healthcare executives. What do they perceive is the risk of these new types of competitive arrangements? So, for example, between the dark blue is strong threat, the light blue is extreme threat. So in total, 67% of hospital executives, healthcare executives, see United as a threat. 66% see the CVS-Aetna merger as a threat. 56% are concerned about what Amazon is doing in the market. And 39% concerned about Google and Alphabet, and 38% concerned about what Apple has been doing. So the change that these organizations could bring to healthcare delivery are certainly creating some angst in our industry. That said, hospital performance seems to be improving a bit currently. There's been stable utilization through 2017. Slight uptick in admits, up 1.5%. Hospital days are up about 1.4%. Surgeries and births are slightly down, but outpatient volumes have flattened. So there was a trend there towards outpatient volumes. They're at just over 40%, but we could have expected that to be higher had it not been for this uptick in admissions. Financially, challenges exist. Medicare is not helping any hospital's bottom line, with losses approaching 11% in 2018 and 2019. This is compared to just 6 years ago. Losses were about 5%. So that's a tough financial impact on the hospital system. Fitch finds that the payer sector is stable and that healthcare in general is stable, but in their reports expresses concern about significant risks, particularly the legal fate of the ACA. If the Affordable Care Act is repealed, it's going to create a tremendous amount of reconfiguring of the healthcare delivery system, and the financial impact on hospitals in particular will be fairly significant as people lose insurance coverage. Ongoing opioid litigation continues to be a threat to the stability of healthcare economics, and the uncertainty of what will happen in the election will be another risk. Not-for-profit hospitals saw their margins relatively flat between 2017 and 18 at about 1.7%. And the for-profit sector, who reports their performance every quarter, as many of you are aware, is showing really healthy increases in volumes throughout 2019. Payers seem to be doing well. It was a profitable year for the individual insurance markets. Rate increases for 2019 were less than 3% for employers and are expected to be smaller next year. But it was also I'm jumping ahead. And employers are doing what they can to reduce health insurance costs. This is strategic plans offered by Mercer, who helps employers manage so much of their benefit costs. And the focus of employers are on monitoring and managing high-cost claimants, focusing on actions to manage costs for specialty pharmacy, big cost drivers for any employer, focusing on creating a strategy around a culture of health, employee wellness, and more advocacy, more empowerment of patients, going down paths of shared decision making and so on. And this year was a milestone year for the cost of healthcare. A family coverage plan topped $20,000 in 2019. That was a 5% increase in overall insurance costs. Worker shares increased by 8%, while the employer share increased by 3%. So workers are feeling more pressure to pay for a larger share of their cost. Employers are trying to keep their costs stabilized, but they're still increasing. But 20,000, that was a milestone. Elsewhere in the payer market, Medicare Advantage continues to be strong, added another 1.6 million new beneficiaries. Now it represents 34% of the total Medicare population, and 8 large insurers dominate these markets. So Medicare Advantage is continuing to increase, and of course, if we think back to the Medicare-for-all discussion, right now a third of Medicare-for-all, no one's really sorted out the fact that a third of all Medicare patients are in private insurance plans through Medicare Advantage. So that will be a challenge for anyone who tries to put together that national health plan. And I wanted to touch on what everyone on this, the 50% of the people on this call agreed was the most important healthcare issue in 2019. The opioid crisis is continuing. There's been some steps taken to address it. And I like this slide, this graphic. It really shows us the 3 waves of the opioid crisis, with launching back in the 20th century with overuse of prescription drugs and a wave of overdose deaths due to prescription drugs. Then about 2010, a sharp increase in the number of heroin overdose deaths, and now being followed by a wave of synthetic opiates, particularly fentanyl, causing even greater deaths per 100,000. So this really is a crisis, and far worse than it was when we started talking about it at the beginning of this century. Back in 2018, Congress, by overwhelming numbers, passed the Substance Use Disorder Prevention Act, again, sweeping majorities, 393 to 8 in the House and 98 to 1 in the Senate. Expanded treatment for substance use disorders, provided funding for residential treatment programs for pregnant and postpartum women, authorized the CDC to provide grants to states and localities to improve monitoring, expanded the use of telehealth services, and also helped stop the flow of illicit opiates, especially fentanyl, through the mail. So that was a major change at a national level. Finally, I'm going to shift towards a brief conversation about disparities and social determinants of health. Many of us recognize that social determinants have an impact on mortality, morbidity, life expectancy, as well as healthcare expenditures and health status and functional well-being. This slide captures the various factors: economic stability, neighborhood and physical environment, education, access to food, community context, as well as the healthcare delivery system. In terms of importance, healthcare is not the leader. It's addressing this is going to happen at the community level. Life expectancy in the United States, we talked about this a year ago, has decreased dramatically, and for the first time we're seeing a downward or a decrease in the age at death in the United States, and for the first time the current generation is going to live fewer years than their parents, something that is reversed a long-term trend of increasing life expectancy. Across our system, we can see some of the significance of those disparities. Back in 2009, the National Academy of Medicine, back then known as the Institute of Medicine, issued a report on how to collect race, ethnicity, and language data, and it launched an era of meaningful measurement. The data we're collecting in our clinics, the data we're collecting in our health plans, and the data we're collecting in our hospitals is far richer today than it used to be. And we can see some of these disparities. On the slide on the left, the number of, we have anywhere from 10 to 22% based on ethnic group, race and ethnicity, did not see a doctor because of the cost, and anywhere between 19 and 35% delayed needed medical care because of the cost. Those disparities leads to those sad stories about diabetic patients that stop taking insulin or use less insulin than they need to survive because of the high cost of those prescription drugs. This is just another example of how disparities impact our health. The slide on the right, what percentage of patients based on race and ethnicity have a usual source of care? It ranges from 75 to 87%, depending on your ethnicity and race. How many have been in to see a doctor in the last 12 months, or a healthcare visit in the last 12 months? A range from 75 to 85 among these 5 different groups, and those who have seen a dentist between 54 and 68%. So it gives us a sense of the opportunities to improve care across all race and ethnicity categories, and the need for better access for the entire population. So I'm going to wrap up with some to-do lists. So given what you've learned today and what you know is going on as well, one thing to think about is Plan B. What will you do if the ACA is repealed? How does this impact your strategic plan? Are you ready for price transparency? Are you ready for patients shopping, whether you're a clinic or a hospital or an ambulatory surgical center, or for that matter, a health plan? Are you ready for patients shopping for healthcare based on price? Something we have not historically done. And how do prescription drug prices impact your system and your patients? And that's a cost of providing prescription drugs to your employees. That's the cost of prescription drugs in the care of patients. Another question: alternative payment models. Are you prepared for the continued expansion by commercial payers and CMS? And do you have the capacity to analyze the data to support risk? If you're not a health plan, you don't have the kind of familiarity with health claims data. Are you able to calculate risk? Do you understand claims data feeds and the nuances of calculating per member per month costs, and being able to project what your population you're at risk for is going to cost you? And then finally, community on the to-do list is to collaborating with community partners to tackle things like opioid crisis and social disparities. Are you collecting good, accurate race, ethnicity, and language data? Are you using the National Academies of Medicine recommendations on how to collect that? And what kind of work are you going to do within the community that will impact opiate abuse, and what kind of strategies have you taken locally to reduce the prescription of opiates to only the minimum necessary amount needed? So that's the to-do list that we're recommending today. And Sarah, I think we have another poll question.
All right, let me get that pulled up here. All right, so given everything that Steve has presented so far today, in this poll question, we'd like to know, in your opinion, what will be the top healthcare story in 2020? And your options here are number 1, the 2020 election. Option 2 is the growth of alternative payment models. Option 3 is consolidation and changing business models. Option 4 is consumerism. And option 5 is still that continued opioid crisis. So we'll give you just a few moments there to go ahead and submit your responses. People are being pretty quick on this one, so they must have been thinking about it during your time here, Steve. Okay, we're going to go ahead and close that poll and share the results. Okay, so it looks like 57% reported the 2020 election, so that's our majority here. Probably not a huge shock. 13% reported growth of alternative payment models. 18%, our next highest group, said consolidation and changing business models. 9% reported consumerism, and then 3% reported the opioid crisis. So again, does that line up with what you would have expected here?
I would expect the elections are top of mind.
It is interesting to see the opioid crisis drop to last place in this one then, after being, the top story of 2019. So we'll see what the year has to bring for that, huh? Okay. And I think you're wrapped up then, right? You ready for the Q&A?
I am ready for the Q&A.
Okay. Well, we have one final poll question for you all before we dive into those Q&A questions. We'll see if we can get that launched here. Okay, so while today's webinar was focused on the important healthcare trends that have shaped our world over the last year and what's to come in 2020, some of you may want to learn about the work that Health Catalyst is doing to prepare for this future, or maybe you'd like to learn about our products and professional services. If you would like to learn more, please answer this poll question. And then we're going to go ahead and leave that up while I pull up our questions here and start passing your questions along to Steve. Okay, let's see, that's a pretty maybe quick answer question here from, I'm sorry, I don't know how to pronounce your name, Joachim. The question is, don't we all get Medicare for all at 65?
That would, yes, that would be Medicare for those over 65 and older. The Medicare for all proposals are being construed at the one end, based on what I've seen of Senator Sanders and Senator Warren's proposals. That would be essentially a national health plan, similar to the Canadian system, with a government-funded insurance plan that all Americans would be eligible for, regardless of age. Some of the less more moderate proposals would be a Medicare for all with an option of buying into Medicare at a cost. But you're correct; everyone 65 or older have access to Medicare.
Okay. Your next question comes from Eric, who asks, why are most of the states that have not expanded Medicaid in the South? So just an opinion question.
That's an interesting question. I would say that partly, so Medicaid expansion allows you to expand Medicaid, which is a state-administered program, but it includes generous financing from the federal government. But I think there may be a reluctance because of the potential cost for the state. I think a lot of it may have more to do with ideology. Republicans in general are less supportive of Medicaid expansion, and the southern states, with the exception of 2, all the states of the old Confederacy are without Medicaid expansion, and I believe that the politics of this might be more important than the cost. I happen to be from Ohio, and Ohio, the Republican uh, House of Representatives and the Republican Senate opposed Medicaid expansion, but the Republican governor said this is crazy. It's money from the federal government, and we're going to be able to address needs of our population, and ended up passing it with Democrat support. So I think that's a common challenge.
Okay. All right. Your next question comes from Evan, who asks, regarding prescription drug prices, there was an op-ed this week in the Salt Lake Tribune advocating against allowing the import of prescription drugs. What are your observations or expectations of how this part of the issue will proceed? And he also noted that the piece was written by a Salt Lake County Sheriff, Rosie Rivera.
Yeah. I actually don't know the answer to that question, and did not get the chance to read the op-ed. I don't know of any risk of having medications shipped across international borders. In other words, I don't see how it would impact availability and access to medications. What it would do is allow for lower prices, because those countries have negotiated lower prices. So I don't know the details of what the opposition would be. Actually, the bipartisan proposal, not the bipartisan, I believe President Trump has endorsed the concept of importing drugs from, don't hold me to this one, but across international borders.
Okay. Your next question, they're pouring in now, is coming from Fred, who asks, why are virtual health offerings not growing despite demand? Is it a lack of competence, lack of funding reimbursement, lack of technology? Another opinion question.
I believe, my opinion is that it's probably lack of competency and competence. The technology is there, and it's been tested out. I mean, there are some successful organizations with providing advanced telehealth capabilities. But building up the infrastructure, training staff are barriers. So I don't think it's a technology issue, and I don't think it's a cost issue so much as it is a capacity, having the skill set to move this forward.
You're getting some supportive comments. Aaron said telehealth and virtual care are not appropriately funded, thus not expanding. So he also kind of commented on that. And then going back to your comment before about the importing of drugs, David Crace had mentioned that pharmacists in the pharmaceutical industry are opposed to interstate drug sales. So that was just a commentary.
So even interstate?
Apparently, according to David. David, if you have any more info on that you want to submit to provide a little more context, please do. Our next question comes from Chuck, who asks, does the cost of family coverage going over that $20,000 level include an impact from rising deductibles?
I'd have to go back and look at, that was a study by the Kaiser Family Foundation. I believe that represented just the, actually I can go back to the slide, maybe I can, this was based on premiums, so this would not, this would be the amount taken out of your paycheck, rather than the deductibles. I'd have to go back and double check the link and reread the article just to make sure, but I believe it is premiums only.
Okay. All right, pull these up again.
Which sounds about right given what insurance costs.
Okay, we're going to skip down to this question from Dean, who asks, How are large insurers able to own provider networks given that they negotiate the rates of reimbursement? Isn't that a form of direct collusion?
I'm going to have to defer to my lawyer on that one. It's happening, obviously. And I don't know if there are exemptions for certain kind of organizations or not. But it is complex, and I do not know the answer. So that's something I need to research for next year.
Okay. The next question comes from Eric, who asks, when do you think environmental factors will be a focus in addition to social determinants of health? The air we breathe impacts a significant percentage of people with respiratory conditions. And we've obviously had a lot, in the world about climate change this year and the issues we're seeing there.
That is actually a really good point, and that is going to emerge as one of the those environmental factors will emerge as one of the new challenges for healthcare in general. The impacting that is far more difficult, though. In the area of social determinants, we know that if people have access to good food and people have access to good health care, and there's primary care physicians nearby, and they earn a living wage, we know that health, without doing anything else, will improve. Granted, air quality varies from market to market, but it's more diffused. I mean, and it's still it's a much tougher. It'll be much tougher to reverse. But that is, when I was doing research for this talk, environmental qualities, global warming, all came up as significant health issues, significant impact on health.
Yeah, maybe in next year's you'll have more to say on that. Okay, your next question comes from Dean again, who asks, how will an ACA repeal impact current operations relative to anti-competition law and price negotiations?
I do not know. I just do not know. I'm sorry.
It's all good. Dean will try and get an answer for you. Our next question comes from Aaron, who asks, actually this looks like it's a comment rather than a question. He just says 2020 election becomes that catch-all answer, responding to MCR-for-all, Medicare-for-all, and the ACA court decision and all else. Mm-hmm. So it's, I guess, it's kind of the one thing, the bucket that everything falls into right now.
Pretty much.
Okay, so moving on, the next question's from Trisha, and I do want to call out anyone who's on the line. It is the top of the hour, the end of our advertised webinar time. Steve has agreed to go just a couple of minutes over the top of the hour, as we do have a lot of questions still pending. So if you're able to stay with us, great. If not, we are recording today's session, and you will be able to hear the Q&A in that recording. Okay, our next one was again from Trisha, who asks, what is the threat from initiatives by large companies? So the identified ones on your disruptive slide, Amazon, Google, those, United Healthcare, all of those. And are they offering something that the current health system does not? Or is it just kind of that fear of the unknown, I guess?
They are offering something that current health system is not. So it's all situational. So in the case of United Healthcare, they're purchasing physician practices, so they will start providing direct health care, and they'll be providing it to their members, presumably at a more competitive cost. If they do it right, they'll reduce utilization, so that's a threat to more traditional fee-for-service type providers, and that's I mean, we know what will happen. We know what could happen. We can look at some of the markets where providers like Kaiser Permanente provide both insurance coverage and care, and utilization rates will go down. Use of specialists will go down. So that's one impact. You know, the you know, when Amazon and Sam's Club are offering virtual visits for employees, that's going to shift care away from traditional caregivers. So it's going to have a financial impact that's going to drive down the amount of dollars that are in the healthcare delivery system. It's going to impact providers, physicians, hospitals in particular, reduce ED visits, reduce surgeries.
Okay. Well, this next question kind of is in that same vein. This comes from Andy, who asks, Google was in the news recently for its partnership with Ascension Health, which brought up a lot of privacy concerns from patients and privacy advocates. Should we expect health data privacy legislation in the new year?
We are going to see, regardless of what happens in the election, I suspect we will see more scrutiny of these types of arrangements, more oversight by the federal government. I don't know if that's going to result in privacy legislation. I think these arrangements that are emerging, I'm sure they're going to have very well thought out answer to alleviate those fears.
Okay, we'll do maybe one or two more questions.
That's fine. Yes.
Okay. All right, this question comes from Megan, who asks, what impact do you believe that Medicare-for-all would have on private insurance companies such as Blue Cross, Anthem, United, etc.?
Well, this is the $64,000 question. Now you all know how old I am. But if Medicare-for-all, as proposed by Senator Sanders or Senator Warren, was enacted, private insurance companies would be, if I understand their proposals correctly, would ultimately be phased out of the business. So the impact would be tremendous. I mean, private insurance companies would be left to provide care for people who were looking for augmentation to the current coverage, or you know, as in places like Canada and England, there are actually private care delivery which you pay for, but you know, so it will be a major disruption to all health insurance providers, payers.
All right. And I think we're still just going to do maybe one or two more. This next question comes from Gerald, who asks, do you expect there to be any increased legislative momentum to have CMS directly negotiate drug pricing?
It's in the House bill that will be dead on arrival to the Senate if it's passed in the House. That negotiating power has not been included in the bipartisan Senate bill, but I think if the bipartisan Senate bill fails, then it goes back to what we said earlier. Everything rides on the next election. If the bipartisan Senate bill does pass, then then it may be something that would be worked on in the future. You know, the biggest argument you hear against any kind of prescription drug price control is that it would undermine the ability of the large pharma companies to do research and develop new drugs. but the flip side is that every other nation, through their national insurance provisions like Medicare, uh, uh, unlike Medicare, negotiate bulk discounts um, on drugs, prescription drugs.
All right, I think we're going to do this last one. We'll see if you have an answer to this one or if I stump you on the final one. This question comes from Matt, who asks, how do you see CMS direct contracting model impacting the landscape described in your presentation in the upcoming years? Do you see more organizations embracing these models?
I do believe that, yes, I do believe that more organizations will embrace those kind of models. I'm not sure that the president will be able to get this through, expand this too aggressively without more support from the Republicans in Congress. And I believe another commenter was that the president does support direct contracting for drug prices, prescription drugs, but he's not on the same page as the majority of Republicans in the Senate. So those hurdles have to be overcome.
All right, I think we're gonna call it there.
Sounds good.
Yeah,
Thank you so
you
much
had
for
lots of
participating.
questions. Yeah, and anyone on the line, if we didn't get to your questions, we apologize for that, for running out of time. We'll still try and get a response back to you, though. So we appreciate you taking the time to submit those. We want to thank Steve for taking the time to present to us today, and we also want to thank all of you for joining us. Please do us a favor and complete the short survey as you exit the presentation. Your answers will help us to deliver more valuable content in the future. And as a reminder, by midday tomorrow, you will receive an email with links to an on-demand recording, the presentation slides, and a transcription.
And my email is on the presentation, so do not hesitate to email me.
That's a generous offer. So any lingering questions, I suppose, that you didn't submit, you can shoot them over to Steve and he'll, do his best to get back to you.